Hello, everyone. Welcome to our day 2, which is our final day of our annual meeting, the SPCC meeting. You know how important it is to us. Today is our last day, and we welcome you all. Thank you so much for turning back to attend to very important issues pertaining to social behavior change in our day 2. Next slide. For now, if there are any new participants, we wish to introduce ourselves to you once again. And my name is Mariam Nabukenya Wamala, and together with me is a colleague with whom we've worked so diligently to serve you in this period, Gabriela Hunter. She is a fellow co-chair. Gabriela, well for the people so that they get to, yes, that's Gabriela. We've been working so closely. And also, before we begin, I would like to share a few logistical notes to you all. First, please select your language for interpretation. There is an icon that looks like a globe. Click there and put your language, and so you can be comfortable while we are presenting. The other thing, next slide, you can follow along with today's presentation slides in English, French, or Portuguese by going to the link on the slide. The link is in the chat, so you can be able to follow through. Our secretariat will send out the slides in all languages, and the recordings will also be shared, and we shall also share with you a report of this event. We look forward to you participating in this great day's deliberations. With that, I would like to officially welcome you all to this virtual forum, which is the Malaria SPC RBM Forum. And today we also have a great theme where we are saying that Malaria SPC in action. And so try as much as possible that we all get in action. Yesterday, we had over 370 attendees on the first day of our forum. And thank you so much for those of you who have been able to turn back today for the day 2. And we hope by the end of today, we shall be counting, and we are about 600 people. Thank you for being interested in this working group. With you, we know that we can move so much forward and we can achieve so much, and we shall get to our endeavors. If you haven't done the needful, please introduce yourself in the chat box, just like we did yesterday. If you didn't do so, do it. Share your name, your affiliation, and the country of origin, or where you come from, so we can tell. Also, we would like you to please note a few things. Today, we would like to take a group photo. Our secretaries, please get ready. I'd like to ask each and every one of us to turn on your camera. And so we can take, in a very short time, we take a group photo, and this will be memorable. Kindly turn on your cameras. Ashley, let me know when you are done taking that picture.
I'll give it just one more moment. I still see some cameras turning on. Thank you so much, everyone. It's so good to see so many faces.
Oh, yeah. Thank you. Thank you for turning on your cameras. We need that picture. You know, if we were face to face, you know how nice our picture would have looked like, but we want to frame it in a way that it was a virtual meeting, but we still had a beautiful picture out there. Thank you. Are we done, Ashley?
Yes, thank you so much, everyone.
Okay, before we begin today's agenda, I'd like to thank our yesterday's presenters. You did a wonderful job. Thank you so much for the presentations. As you can see, we had Dr. Corinne. You can see the presentations that happened yesterday. We are so grateful for everything that happened and all those that moderated. Thank you so much. As you see the screen, I may not be able to read every name, but thank you. Yesterday, we received an email I hope you got the takeaway messages. All of you got an email of the takeaway messages. And the key issues was we stated, and one of them was that malaria was bouncing back. And so we needed to strategize better. We also need to use data to segment our audiences. And I can see a lot of data is coming through. We need to focus on our attitudes in the countries where we implement our work, the perceptions, the knowledge, and also look beyond those key areas. So we were reminded of that, and we can see a lot of data that is guiding all this in your countries. We also need to put our SBC data on a map, kind of doing a spatial analysis of our message exposure, recall, and you saw all that happening in our presentations. Next slide. Next slide, please. There was a Twitter. If you looked at the Twitter, our dear CEO, there was a tweet, a very important tweet. You can also tweet it and also go to Springboard and also post it as many times as possible. And also, thank you so much for sharing all these important messages out there. Use this platform for any information that you get to share it out broadly so that everyone can be able to view it. Next slide. We are still going through our takeaway messages. You can also share all your takeaway messages on Springboard, whatever you learned, and we shall be able to broadcast it out there for everyone. Now let's go over today's agenda, and it is as follows. Kindly bring back today's agenda. It's important for us to follow. Today, we are going to be receiving a program manager representing all program managers and an M&E officer representing all M&E officers for a perspective in understanding how we relate with them as we are implementing our SPCC work. We shall also have a presentation on RTSS for the vaccine introduction. And then after, we shall have our lighting moment talks like yesterday. And then we shall end our virtual forum. So those are the topics of our lighting moment: the social behavior change communication interventions, the community approach of religious leaders in Mozambique, and then a synergy between frames of faith leaders and advocacy, and then community action approaches. And generally, we will look at the health provider behavior change at country level. Next. Yes, the comment, I spoke to that. We're also going to look at the impact of radio programming, the segmentation of healthcare providers to inform malaria SPC implementation, client provider behavior change and use of effective models for behavior change through information, education, and communication. We are also going to look at that. So be interested in our lighting moments. When we break away, enjoy the lighting moments. Thank you. I think I'll now pass over to my colleague Gabriela to take us through the next part of the agenda.
Thank you, Miriam. We can go back one slide. Oh, I'm sorry. Go forward. Thank you. I'm pleased to introduce our first session today. We have recorded updates from our fellow RBM Partnership to End Malaria working groups. On the next slide, we've taken some time to think about ways in which our working group intersects with the other RBM technical working groups. And you can see some of those ways here on the slide. For the most part, it's clear that SPC can support many of the key interventions under vector control, preventing malaria in pregnancy, and malaria case management. Listed here are some of the behaviors that we promote to support those technical areas. And we also think there are important connections to be made for monitoring and evaluation of SPC programs more broadly and in a more robust manner, and looking at ways we may be able to interact with some support from the surveillance monitoring and evaluation reference group for that. Finally, we can look at how multi-sectoral action can help create an enabling environment for SBC programs to operate, and one that will support the practice of the malaria behaviors that we promote among communities. So today we'll hear from the Malaria and Pregnancy Working Group, the Surveillance Monitoring and Evaluation Reference Group, the Case Management Working Group, and then the task team on anthropology and human-centered design that falls underneath the Vector Control Working Group. So I'll now just pass the floor over to Ashley, who will play the recorded updates for us.
Good morning. I'm Julie Gutman, and along with Maurice Bukagu, I'm one of the co-chairs of the Malaria and Pregnancy Working Group. While I'm very sad not to be able to join you in person today, I'm pleased to have this opportunity to present to you the work that we have been doing. To remind us all why malaria and pregnancy remains a huge problem. Over a third of pregnancies in sub-Saharan African countries were exposed to malaria infection, totaling 11.6 million pregnancies in 2020. As a result of these infections, nearly 820,000 infants were born low birth weight, and 164,000 infants were stillborn. This represents 20% of all stillbirths in sub-Saharan Africa. Despite the substantial impact, we see that still only half of pregnant women are sleeping under an ITN, and only a third of eligible pregnant women receive the recommended 3 or more doses of IPTP. Despite the majority of pregnant women attending at least one antenatal care visit, 17% of women who attended antenatal care did not receive any IPTP. The purpose of the Malaria and Pregnancy Working Group is to align RBM partners on best practices and lessons learned in malaria and pregnancy programming to help achieve higher coverage in MIP interventions globally. We promote and support WHO strategy to control MIP, including promoting the use of insecticide-treated bed nets, effective case management, and provision of intermittent preventive treatment, or IPTP, in areas of moderate to high malaria transmission. We promote advocacy through development of key tools and products targeting policymakers and program managers. We support research and the documentation of best practices and lessons learned. We promote partnership between reproductive health and malaria control programs. And for the past 2 years, we've been supporting a call to action for IPTP to improve the coverage, specifically highlighting the need for attention to malaria and MCH programs in the COVID-19 context. Additionally, we coordinate and collaborate with other RBM mechanisms, including the MERG, to develop M&E guidance for malaria and pregnancy. As you can see, we have a number of areas of collaboration with various working groups. Of relevance to this group is the products that we've worked on with respect to monitoring and evaluation of IPTP delivery and ITN use. Additionally, it's very important to ensure a standardization of indicators and reporting across countries to ensure that data are comparable across countries. To highlight, as you can see, while we've made great strides in the progress of coverage of IPTP3, shown in green in this chart, in the past year, we've seen a drop in coverage as a result of the COVID-19 pandemic. At the current levels of IPTP coverage, it is estimated that 422,000 low birth weight births were averted. However, if all of the pregnant women who visited antenatal care once also received a dose of IPTP, it's estimated that an additional 56,000 low birth weight infants would be averted. This represents the substantial missed opportunities that we are trying to reduce with the call to action. The call to action motto is speed up, scale up for IPTP. And the goal is to reinforce what's already happening and highlight the rationale to continue to prioritize and address malaria in pregnancy. This includes strengthening relationships between malaria and reproductive health, looking at innovative ways to increase IPTP and ANC utilization, and ensuring the continuation of IPTP and ANC for pregnant women during the COVID pandemic. I would like to invite you to visit our web pages, which highlight the work that we've been doing. As you can see here, we have a number of videos from our malaria and pregnancy champions calling for attention to the Speed Up, Scale Up campaign. What can you do to help increase IPTP? Please join our IPTP call to action. We have webinars and events. You can share the call to action tools and products, support our social media efforts, and most importantly, sign our letter to world leaders. The link is here below, and I will share it with the co-chairs by email. We are hoping to get 1,000 signatures, so we invite you to join us in bringing your name to our letter to world leaders to advocate for increased coverage of IPTP and increased funding for IPTP. Thank you so much for your time and attention today.
Hi, everyone. Thank you for the chance to give you updates from the Surveillance Monitoring and Evaluation Reference Group. I am Molly Robertson, and I'm presenting on behalf of myself and Madoun Diop, my co-chair for this working group under RBM. Our task is really to create some harmonization across the partnership, best practices and idea sharing around issues of surveillance, monitoring, evaluation, indicators, and best practices and sort of data use for decision making. What I would like to go through with you is the results of poll at the last meeting that we had, which was earlier this year in Kigali. And what we did was throughout the meeting, we gathered everyone's ideas of what the next step should be for the SMERG in looking across the partnership. As you can see here, we ranked these, and the first ranking was gathering and disseminating best practices for local data use, really continuous quality improvement systems, and using data within subnational areas. We also had developing strategies for surveillance monitoring and evaluation resilience. We had a great session on resilience in the Kigali meeting. This was really talking about how to create adaptive and flexible surveillance monitoring and evaluation systems that meet the needs for countries that are looking at areas of emergencies, climate change, migration, some of those areas which are really hard to measure, and also thinking about what the adaptations are as burden reduces in different areas, how to create systems that are able to flex and respond to all of these different challenges. The other two that were at the top of the list was sharing best practices in estimating population. So I think we all know that knowing who is the where, when, especially in some of those contexts that require some resiliency, is sometimes difficult. And really identifying and sharing what the best practices are for estimating those populations is really important if we look at disease burden and some of the other pieces in terms of implementation strategies. We also talked about harmonization of activities around data warehouse or data repository. This was really a discussion of how we have more and more data. We have more and more data at a granular level. How do we make sure we store, house, share that data and are able to access it and use it? What are the best practices that we have seen so far? And what are some of the challenges in making sure that that data is available, updated, usable, and used? There are many other things that came up, and I will share the slides, and you can look through them. But I just wanted to highlight those as really, the partnership's decisions on what is most important to move forward with. One of the other pieces of the SMERG that is very active is the Surveillance Practice and Data Quality Committee. This is led by Dr. Balthasar Condrino and Dr. Ranshak Roca-Felterer. I wanted to give you some updates on their behalves. They have really developed a great resource for understanding what partners are doing in terms of surveillance and under surveillance, what are the activities, and mapping that out across different countries and in different regions. Here you can both go to the dashboard and see the different partners' activities, and you can also add to that if there are new activities to add. The new projects should be submitted until for the 14th of October, and then that will be updated. There's also a webinar series that they have been conducted that is very popular, and I would definitely suggest if you're at all interested in looking at that. The next one will be how data visualization informs decision making, looking at end October. They'll have panelists from the different countries, and I think the moderator is still to be determined. There is also a newsletter that the SB and DQ committee sends out, and I would also recommend that that you get in touch with the Secretariat of the SMERG if you wish to be added to that newsletter. The schedule for the next SMERG, we are going to have a very small meeting that will be tied to the ASTMH in Seattle. This will be on Wednesday, the 2nd of November starting at 4 p.m. We will just give opening remarks and kind of walk through the agenda. What we want to do is focus on some of these updates from the SP and DQ committee, and then we want to go into the two main pieces that we felt were coming out of discussions with countries, which was the continuous quality improvement systems. And the granular data, how to implement improvement activities at a granular level. So those are the pieces that we're going to focus on, and we will, and as well on some of the issues that relate to resilient systems in those aspects. We will then determine from that meeting how we will move forward with that. What is the best way that we can start to work on those pieces, and hopefully have some traction on getting some best practices shared for that. So I wanted to make this quick, and this is all the updates I have. Thank you very much. Please get in touch with myself, with Madoon, with the secretariats. If you would like any more information, if you would like to join our meeting in November, we would very much welcome you. Thank you so much.
Good morning, good afternoon, good evening, wherever you are. I'm Larry Barrett. I'm the Technical Director of the PMI Impact Malaria Project and the co-chair of the RBM Case Management Working Group. On behalf of myself and my co-chair, Elizabeth Juma from WHO, we'd like to greet you at the SBC Forum. I'd like to cover two things. One, some work that we're doing in the case management working group, and two, one of the activities of the SBC working group that's of interest to us case management folks. We recently, back in June, had our first in-person meeting in, I believe, 3 years in Kigali. It was well attended. More than 20 NMCP representatives were there, as well as many partners. And the topics of our meeting covered drug resistance, severe malaria, diagnostic testing, and monitoring and evaluation of case management. The recordings for the sessions as well as the meeting notes are available on the Case Management Working Group website, as well as copies of all the presentations. On that, the last topic that I mentioned on monitoring of case management, there has been a growing consensus for a number of years that the indicators for malaria case management really aren't up to the task. Unlike the indicators for ITNs and IPTP and SMC, case management indicators are both a bit outdated and a bit inconsistent in how they're collected. Some examples, particularly those indicators that are based on data from household surveys such as DHS and MIS, often rely on fever as an indicator for malaria. In the early 2000s, when those indicators were developed, that made sense because the vast majority of fevers, particularly in sub-Saharan Africa, were malaria. That is no longer the case, and in some countries, malaria is a minor cause, particularly those countries moving towards elimination, is a minor cause of fever. So indicators that use fever as a proxy for malaria are somewhat obsolete and probably need revisiting. Another problem we see is that many HMIS indicators for malaria are often inconsistently collected from country to country, and as a result, it's difficult to draw cross-country comparisons or monitor progress. Because of that, we are working on an initiative to revisit, review, and potentially revise malaria case management indicators in cooperation with WHO, the Global Fund, PMI, and other partners, and that will be taking place over the next year or so. Those who are interested in that, we will share information as it goes along. In terms of the SBC working group activity that is of interest to us, not surprisingly, it's the SBC toolkit for community health workers. Obviously, the Case Management Working Group has a great interest in community health workers because they deliver malaria case management services through ICCM or sometimes malaria-only CCM. Obviously, I think there's a lot of overlap in the activities we're working on, and just a quick message that we would, as the Case Management Working Group, would be very interested in providing inputs and perhaps having an opportunity to review that toolkit before it's finalized. So again, anybody who's interested in the Case Management Working Group can check our website on the RBM website, and feel free, if you have questions, to reach out to me or my colleague, my co-chair, Elizabeth Juma. Thanks very much for listening, and I wish you a good meeting. Thanks. Bye.
As many of us have seen firsthand in our own work, people are essential to the success of vector control interventions. No matter how efficacious a new tool is, it'll only be effective if people actually use it. Unfortunately, human behavior hasn't always been adequately considered in the development, evaluation, or implementation of vector control interventions. I'm happy to share a brief update on a new task team within the Vector Control Working Group that's designed to elevate the importance of human behavior and human-centered design in vector control. This task team came out of a growing recognition of the importance of human behavior in vector control and growing interest from VCWG members. Through the task team, we hope to provide a platform for engagement and exchange to document lessons learned and best practices and to support opportunities to expand application of human-centered approaches among professionals and organizations working in vector control. I'll share a few of our priority activities for the coming year. In terms of providing a platform for engagement and exchange, we see this both within the Vector Control Working Group, but also opportunities to increase coordination and collaboration between the vector control and social and behavior change working groups. We've identified 2 key technical areas to focus on for documenting lessons learned and best practices. This includes providing guidance on integrating human behavioral and entomological data to better understand gaps in protection for malaria, as well as contributing to the Anopheles stephensi response in Africa. This will include bringing together groups working on social and behavioral research for Anopheles stephensi, as well as contributing to broader discussions on the regional response. Finally, supporting opportunities to expand understanding and application of human-centered approaches. We've already facilitated an introduction to human-centered design for malaria professionals, which I'll highlight in just a moment. And we'll be curating a list of experts and groups working on human behavior for vector control as a resource for groups working on this in the space. Finally, I'd like to shine a spotlight on one of the activities that we've done so far with the SBC working group that was quite successful. And that was a hands-on introduction to human-centered design for malaria professionals. Based on the wonderful demand that we saw, we were able to host 3 separate 3.5-hour workshops in March and April. With that, I would like to thank you all for the opportunity to share these updates, and we look forward to future opportunities to collaborate with the SBC working group. Thank you.
Wow, thank you very much, everyone. Thank you, Julie. Thank you, Molly. Thank you, Laurie and April. These have been very wonderful presentations. Thank you so much for appreciating that BCC is a very important component, and as members of the social working group, I think you notice that we cannot operate in isolation. We need the technical areas so that we can be able to move together. I also want to emphasize that when you look at countries, we focus our indicators on early treatment seeking behaviors in terms of the behavior indicators for case management, the test and treat, and we've been able to achieve on those that we have supported so well. Test and treat in most countries is high, and also early treatment seeking behaviors are happening and growing every day. Malaria in pregnancy, the indicator of IPTP is growing every day, and early line use among pregnant women is also growing. For MAG, as you can notice, we are very much interested in the research and documentation of our success stories. You will always be coming in to support us. And I also noticed that case management is interested in the tool that we are working on. And indeed, I want to also take this opportunity to thank the leaders on that tool development. Shelby and Deborah, you've done a good job, and we shall definitely share the tool for the case management team to review. Thank you so much. And we will continue having this synergy of coordination amongst the technical areas. Now, at this point in time, I'd like to introduce to you the next team that is going to be presenting to us, and this is going to be very interactive. We are going to have a panel who are staff of the National Malaria Control Programs. We wanted to bring a new perspective of variable members that we normally interact with. We want to hear from leaders within the National Malaria Control Programs who are champions of SPC. And you see, when I speak about social behavior change, I even give a smile because this is our area that we are pursuing, and we know it is so much dependent on human behavior. We hope that hearing from these panelists will give us as SPCC practitioners new ideas on how we can engage our colleagues in these thematic areas to continue and further the SPC cause. We will ask our panelists questions about how SBC has contributed to their malaria programs, and also share their experience on how they've been champions, how they've advocated for SBC in their lines of duty. First of all, I would like to introduce Dr. Amiable from the Republic of Rwanda. He is the manager of the National Malaria Control Program, and they deal with other parasitic diseases and NTDs within the program of the Ministry of Health, Rwanda. And since 2026, he has been widely involved in the design and implementation of national malaria control strategies and guidelines for malaria and the tropical neglected diseases at all levels. At the same time, let me also take this opportunity to introduce to you the M&E officer for Mozambique, Samira Sibide. He is also here to share with us his experience on working with the SPC working group. Samira is at the Directorate of the Public Health of Mozambique. She has a great a degree in biological sciences and from a university in Mozambique. He's also has a master's of health sciences from Brazil, and he's also a PhD student currently. And so you can see that we are having very good resources. So today's perspective of SPC is to have these panelists answer a few questions. And if the panelists are online, kindly, we are going to take you through this session. You are very welcome. I would like to see the panelists online. I'll take this session together with my colleague, Gabriela. Gabriela, have we checked through it? Samira, yes. Samira, you're there. Can you wave to the team so that they don't confuse me and you? Please wave now.
Sim, estou aqui. Bom dia. Boa tarde, desculpe.
Yes, I'm here. Good
Yeah, bom dia.
Good afternoon or good morning.
Thank you. Good morning to you. Dr. Amibe?
Doutor
Hello.
Aimable?
Hello, everyone.
Presente?
Yes.
Sim,
Dr.
estou.
Aimable?
Hello.
I call him
Hello.
Dr. Amiable.
Hello.
Yes, thank you. That's Dr. Amiable. Thank you so much for joining us, and I'll take you right away to our first question. And our team of SPCC practitioners here, we are about 300 people who have joined the call since yesterday. So they are all listening in to you. Our first question today to both of you is we would like to understand how you have, SPC has contributed to your malaria program. And Dr. Amiable, please, you can take the floor to give us an experience of how SPC has contributed to your program. Thank you.
Yeah, thank you, Mariam. Can you hear the voice?
Yes.
Sim, podemos ouvir.
Okay, cool. Yeah, for Rwanda, we have worked with local NGOs, but also different partners in malaria response from 2020 mainly. And from there, we had a high burden of malaria in different areas for the country. And when organized the mass campaign for bed net distribution, we had to work closely with the local NGO to support in mobilizing local communities, but also during the IRS campaign, targeting 12 districts, local NGOs and other communicators were very key in this area. Case management as another area of malaria response. We make sure that people at community are getting tested and treated on time. And this is a key role of local NGOs in mobilizing people to get treatment on time. And the key results include a reduction in malaria incidence. From 2020 up to now, we could see a 62% reduction in malaria incidence, whereby we dropped from around 3 million, around 4 million malaria cases nationwide to less than 1 million last year. this is a big contribution, of course, of malaria prevention interventions, but also local NGOs supporting 60% reduction in severe malaria cases as well, and also death due to malaria. And I think this is a clear indication of how SBC is really supporting. And before using local NGOs, those results were not really there. And you also have other partners like a PMI supporting in SBC as well. Over to you.
Thank you very much, Dr. Amebo. I noticed that in Rwanda, we are having the NGOs supporting so greatly the social behavior change pillar, and they help in the mobilization for all these very many activities. And so SBC is contributing, and how this is how you're appreciating. And I hope that even other colleagues in other countries will appreciate that NGOs really support the SBC. To you, Samira, would you like to add anything from your M&E perspective?
Sim, muito obrigada.
Yes, thank you so much. Our malaria program in Mozambique, we have the SBC area that supports other areas of our program, such as prevention, that we have the nets. We are also, we provide support in all residents, and now we are currently including all the country, such as the treatment, mass treatment for all the population, SBC, is also for children. So SBC has been working a lot, as helping us a lot in Mozambique, much more in the prevention area, improving our indicators that we have in our country. So especially with the use of ITTN and NET, this has always been supporting the perception of the population, because back in the past, population would not accept the ITTN in the residents, but we SBC is helping us a lot, and the acceptance indicators are really, really great. So regarding the pregnant women, our indicators has really, really improved for the prenatal visit, and also the use of ITTN and NET, as well as going to the health facilities. We have been noticing the adherence to the health cares has been increased. We have had more appointments in our health centers. In our community, we notice the work with the population, rather engaged with the health committee that we have in all, with leaders. We have teachers, we have all the religious leaders that help us with the compliance with all the care that we provide against malaria, as well with the community leaders in all levels. I would say we have the support of our community leaders of all the provinces, as well as the national level, with the help and the support of the president. So there is indeed a huge work that is being doing by the working group at SBC, and is supporting our program really well.
Thank you so much, Samira. We really appreciate you that you're bringing all this energy into the practitioners of social behavior change. Dr. Amebo, thank you so much. You make us feel that we are very important, and we are an important component of the malaria prevention. And I'm sure all the colleagues who are online are now feeling energized with listening from you. Let me pass over to my colleague Gabrielle to take us through another set of questions.
Thank you. Yes, so moving into our second question for our panelists today, Dr. Imable, from your experience, what is an effective way to include a robust budget for SBC in country global fund requests or in mobilizing domestic resources? for malaria SBC.
Yeah, thank you, Gabriel. I would say first that challenges may create opportunities, because before 2020, the malaria program had been using conical standard net nationwide, and no strong SPCC was in place. No local NGO to support, but only one single staff in the program was coordinating all effort for SBC. Then you had to submit our Global Fund application for the grant 2020-2024, and the conical net were not an option because of the high cost. Our data also had shown that mosquitoes in Rwanda had developed resistance to pyrethroid using those standard nets. And we had to introduce PBO net and IG2 net, which were rectangular net. These are few challenges that we have been facing. And also we knew that the population of Rwanda prefers using conical net for easy handling. These are key questions we had to address. And because of this background, as we developed our new strategic plan, we advocated for SBC to support in that complex shift, changing from conical net to rectangular net, making sure that people who prefer conical net are now using G2 net, PBO net, which are rectangular net, and you had no other option. And on the other side, Global Fund was asking us to give results of those new types of net introduced plus IRS. And the only way was to make that case and ask them to provide additional fund for SBC. We make sure that people properly use rectangular net. They prefer conical net. You are giving us rectangular net. Please give us money for SBC. This was an opportunity, but created by the challenge. And from there, we put key indicators on SBC on which local NGOs will be reporting on. And they said, we are okay. Since we can see 3 community-based indicators, we are okay with that. But on an annual basis, please report back to Global Fund. And this was the same for PMI. They also procured for us PBO net, and they had to make sure that they have a component on SBC to make sure that people use those net. I think from there, we now have 7 local NGOs currently supporting the program, but using PMI Global Fund money, but that was created by those challenges. The government also is supporting, of course, because through the centralization process in Rwanda, we try to train district and sector staff involved in integrated vector management. With the support from Global Fund and the PMI, we train government staff, usually dedicated to agriculture, hygiene, but we train them on how to change the behavior of local communities. This integration also helped us mobilizing additional fund from the government, from PMI and Global Fund as well, to make sure that we implement integrated vector management through SBC, not communicating through radio, sport, TV, or banners or leaflets, but changing behavior of people through practice. I think this is just what I can say. Challenges can create opportunities, and Global Fund, PMI were open to support based on that background. Over to you.
Thanks, Dr. Aimable, for sharing that experience from Rwanda. I think it is a really great experience for many of us to take away and think about and learn from, how a challenge created an opportunity and how you took advantage of that opportunity to increase the funding envelope for SBC to meet the broader needs of the malaria control program. So thank you for that. I'm sure, Samira, that robust monitoring and evaluation is also crucial for creating a strong funding request for SBC. Would you like to add from your experience, please, on monitoring for malaria SBC and funding?
Obrigado, Gabrielle.
Thank you, Gabrielle. Well, when it comes to Mozambique, we have a lot of funding from the Global Fund. We work in coordination with Global View and the level of the entire country. And we have some sub-receivers that are organizations that are funded by the Global Fund to do the SBC work. We have advanced, but in the last years, when it comes to monitoring, we have noticed that the country need evidences of cost effectiveness of the interventions that are being held in the community. So there's a need to see what the impact is. What is the impact that the country has when it comes to these interventions? For the Global Fund, what we would ask is that maybe in the future for them to include that evidences when it comes to the cost effectiveness of the interventions. And there are many interventions when it comes to SBC. We would like to know what are the results? How is this group that is working in the community, how do they influence, in fact, in their behavior? Would like scientific evidence in regard to that. We haven't had that so far. Also, when it comes to measuring what the impact is, we don't have instruments in the country currently that are able to measure the work that is done with this intervention. So we are lacking instruments, such as, for instance, how do we do the segment of the patients in sanitary centers? How do we know how many patients come to us in the sanitary centers that were referred to by the volunteers? We don't know that information. That would be very relevant to us because it would help us to prioritize where we have more challenges and direct funding to those areas. We also think that with these data, it would be important to use these data and cross them with epidemiological data that we have. We have some regions that have low, medium, and high, so it would be important to use these data epidemiological data that we have in the country and cross them over. We think that in the Global Fund could look more towards that. That would be great for the country. And we think that in the future, we can include this in the requests that we are going to make. Another thing that I'd like to share has to do with national resources. We created the national fund. It's a malaria fund in the country in which the head is our president of the republic. We had a national forum for malaria created, and this fund is fed through national companies. That for us is relevant because we already have a national fund. In the past, we didn't used to have that. We only depended on the Global Fund in the past. Now we already have the National Fund. And for smaller malaria things, we're starting bit by bit. We can already direct funds for that. That's what I'd like to share, Gabrielle. Thank you very much.
Thank you so much, Samira. You have given us a lot to think about. You've highlighted some major needs in terms of providing the data that's needed to show the impact of SBC at the community level, to use that for funding requests. And we appreciate that you've also shared the experience from Mozambique around the development of a national fund, and hope that there are ways that that fund can also support SBC. But it's a really good example as well for others who are listening. Thank you. Let me pass it over to Mariam now, who will ask our final question to our panelists.
Obrigada, Samira, and
thank you, Samira.
Dr. Amibo. We now have our final question to you, and I'd like to start with you, Samira. How can M&E managers support the work of their SBC colleagues to incorporate and track SBC indicators in the M&E framework? by sharing your experience at country level.
Obrigado, Mariam.
Thank you, Mariam. In the level of the country, what in terms of assessment or evaluation we have done, we created a platform. It's an integrated platform of information, malaria information. And there we have a lot of indicators of several program areas, case management, prevention, and also SBC. SBCC, unfortunately, was the last one to be incorporated. We're still developing it and enhancing the platform, but it already exists. There's already some SBCC data there that are introduced on the level of the community, the district, which is like the lowest level. And these data are introduced from colleagues that work in this area, that have a world view, like the government itself input information in the platform. And this information is available for everybody who works with malaria. We have dashboards in which you can see the information through graphs, tables, information on the level of the communities. But also, we integrated and we think about improving this, the SBCC colleagues on the level of our malaria program in the technical groups of the program. So we have technical groups, technical discussion groups of each area of the program in which the SBCC colleagues are there integrated. And we are in the technical group of SBCC. We in the monitoring and evaluation are part of this group. And that's good because this way we're able to get the information, get to them, and they can get the information to the other colleagues in other areas and in other districts. There are several levels, several tiers. But this is something that we did on the level of the program. We created a research agenda. We have a national agenda for malaria, but we also have an internal research agenda for the program. And there's the SBCC elements there. In this agenda, we've already identified the ones that are relevant for the program, and we have incentivized that all the intervenients, all the stakeholders that work with malaria to research in these areas. So these are the points that I mentioned here. That is how we support the SBCC on the level of Mozambique. Thank you very much, Mariam.
Obrigada, Samira. That is very, very helpful. And the participants online, I'm sure they are taking a leaf on how we can collaborate with the M&E officers at country level. And we can really achieve a lot. We can document all our success stories. We can look through our indicator reference guide and be supported to have our indicators flow very well. Now, to you, Dr. Amiable, we would like to have an experience with you to share with our practitioners. We want to understand that effective message that an SB officer can carry along to a program manager from this meeting. We want to see your suggestions on how SBC officers can be helped at country level to advocate for malaria SBC within their programs. What is that take-home message from this meeting? As we wind up, this is our last question to you. Thank you.
Yeah, thank you, Mariam. I think you to see that SBC component is like a neglected intervention, and the people you to focus on malaria prevention. They procure bed nets, they procure RS products, they procure rapid tests for diagnosis and treatment, but they don't think of having SBC as a core intervention. This is one clear message, and think that success of those interventions always should come from the quality of the product. Yes, you need to procure quality net, effective test, but if the coverage, if the access, if the use are very low, do not expect a success. And the coverage, the use should come from the SBC. I think this is one of the guidance to SBC officers that yes, program managers focus on the quality product deployment plan, but think of the coverage if you need a success. Second is that we need to also use data as SBC experts. We need maybe to show that if the coverage of bed net use in pregnant women as a high-risk group is very low, you need SBC expert as us to help you increase that coverage. I think this is another clear message to people and mainly program managers, but also other decision makers. We also need to shift from the general message disseminated through radios, TV. General message, just investing like in designing nice banners, different colors. But if we don't change and move from the radio to the ground to make sure that an old woman receiving a conical net or a nice PBO net is properly using that net, you are not really addressing SBC component. Let's say that maybe that PBO net that is well working is not properly used. You need to understand what is the challenge of that old woman at village level. Probably the roof is very high, so that maybe a rectangular net is not able to reach the anticipated height. I think it's now where we need to move from the general SBC strategies and go to the practice. Telling people that please always do hygiene, but you don't go on the field and see where those breeding sites are. For example, where those people are keeping water, you need to go there and educate by demonstrating how maybe to cover that container so that mosquitoes may not come and lay their eggs. This is how I think as experts should also be changing our behavior so that we change the behavior of the community. And with this in mind, I think like engaging different stakeholders, but also training them on how to use those interventions and how to help people change their behavior, that would be very key. SBC is not really a matter of SBC expert at central level, but we need other layers like farmers, like district staff, like local authorities, like agriculture people, because addressing mosquito bite is beyond the Ministry of Health, is beyond the National Malaria Control Program. We need to engage those rice farmers, those community health workers, and they need to have the same level of understanding. Why do we deploy PBO net, not standard net? People need to understand clearly before they change the behavior. Why do I need to cover this container? I need to understand, but also it's better you show me those mosquito larvae that I can understand that that container is a threat to the family. But if you say no, in that container, you may find mosquitoes. I can spend like 1 or 2 months without finding a real mosquito in the same container, because what I could see is only mosquito larvae. I need to see in that container, how can I identify those mosquito larvae so that I know next 2 days, those will be transformed into adult mosquitoes that will come to bite me. You see, this is kind of new approach for the communicators if you need to understand or to convince people that you are needed or you have a solution. I think these are a few comments I need to highlight before I close. Over to you.
Thank you very, very much, Dr. Amebo and Brigada Samira. We very much have appreciated you. Thank you so much for sharing those insights. I am sure the team here has appreciated, and I know that from today onwards, they are aware that we have champions within the programs. Thank you so much for being malaria champions. Samira, you know, we had our meeting at some point in Mozambique, and I am glad that you are still on board with us and you're still our champions, sorry. Thank you so much. And Dr. Amebo, we always count on you, and we shall always call you in these meetings to enlighten a number of things. To us, the practitioners, First of all, it is very clear that SBC has caught the attention of the leadership of the National Malaria Control Programs. And then as that happens, we also have to be very proactive to relay our information and also to make sure that we can obtain resources to further our agenda. And as you have noticed that it's important to keep engaging all the levels. Dr. Amable has mentioned very clearly that it's not the National Malaria Control Programs to solve the problem. It is beyond us. It is multi-sectoral. Everybody has to come and pick a piece of it. You've heard from Samira, the engagement of every layer, the schools, the old people in the communities. Really, we need to design our strategies that are very comprehensive and also be aware that no single approach is mutually exclusive to bring out what we want. We need a set of all the other approaches to make sure that we get what we want. Thank you so much, our panelists today, and we've made this very lively, and I'm sure our colleagues have enjoyed the panel. Thank you. We shall meet again. I would like to pass over the floor to my colleague Gabriela to wind up this session.
Thank you, Miriam, and thanks again to our panelists. We heard some key messages coming through, and one is that SBC professionals can certainly consider that they have allies within national malaria programs who will help obtain resources for SBC and support them. However, it is on us to interest them and other leaders in SBC. And one important way we can do that is by providing evidence of the results of the work we are able to accomplish, even with our small funding envelopes. Which leads to the second key message that we've heard come through. We hear there's a need to strengthen coordination between monitoring and evaluation and SBC for more countries to generate robust and usable SBC data. And we appreciate the examples shared from Mozambique on how SBC data is integrated into a national malaria data system. And so where there are routine reporting systems, we should advocate for SBC to be included and communicate that to our monitoring and evaluation colleagues, letting them know that we do have actually a set of very robust and quantitative indicators for malaria SBC, and we can communicate that to gain their interest. Remember, we have our indicator reference guide, and we also have the Malaria Indicator Survey SBCC module. These are two excellent sources of SBC indicators. They're both found on our working group website, and we can put that link to our resources page in the chat now so that you can find them easily. And finally, while we talk so much about having a funding gap, it is also important to recognize, as our panelists did, and share gratitude to the development partners, bilateral and multilateral organizations that fund SBC for malaria. We appreciate them for prioritizing SBC across the globe, and hope we can see an expansion of that with other partners joining in as well. So with that, a final thanks to our panelists, and thanks to everyone for listening and sharing your thoughts in the chat. I will now pass the floor over to Avery to take us into our next session. And I will ask for the slide sharing to start up again as well.
Thank you, Gabrielle. My name is Avery Avrakatis, and I'm a senior policy advisor with the U.S. President's Malaria Initiative and a member of the RBM SBC Working Group Steering Committee. Before we begin our next panel, please remember to select your preferred language using the interpretation button at the bottom right-hand corner of the screen. Slides are available for all presentations in English, French, and Portuguese at the link on the screen and in the chat. As many of you may remember, the RBM SBC Working Group had a panel on the RTSS vaccine at last year's virtual forum. For this session, the steering committee is thrilled to build on the lessons we learned last year and the many new developments we have seen over the last several months. Today, I am joined by Elena Ballister-Bond of the UNICEF Eastern and Southern Africa Regional Office, and Dr. Rose Hulongo, the lead of the Kenya Ministry of Health National Vaccines and Immunization Program. Next slide. And next slide. And I think next slide, thank you. Before we hear from our presenters, I would like to share a brief
Antes de passar para os apresentadores,
jog our memories about the
quero
for the RTSS vaccine.
a mensagem sobre a vacina contra a malária.
Avery, one moment. We can hear the
Apenas
on the English channel. If the interpreters can please check their devices. Thank you, and back to you, Avery.
Thank you. In October 2021, the World Health Organization Director General Tedros announced the official WHO recommendation for the RTSS vaccine. He shared, "This is a historic moment. The long-awaited malaria vaccine for children is a breakthrough for science, child health, and malaria control. Using this vaccine on top of existing tools to prevent malaria could save tens of thousands of lives each year." Next slide. The RTSS vaccine was designed for use in children in regions with moderate or high transmission of malaria caused by Plasmodium falciparum. The RTSS vaccine builds on more than 30 years of research and development, and WHO's positive recommendation for the use of RTSS was announced in October 2021. Soon after, Gavi, the Vaccine Alliance, announced the initial investment of a USD 155.7 million in funding for the years 2022 to 2025. There are ongoing application windows for RTSS introduction in many countries. As many of our members heard during our recent webinars and general calls, the RBM SBC Working Group launched a work stream a few months ago to coordinate with the Gavi Malaria Vaccine Coordination Team to develop global SBC guidance. The vaccine, next slide, is administered through a 4-dose regimen, with the first dose starting at 5 months of age. The first 3 doses are administered a minimum of 4 weeks apart, and the 4th dose is intended to be administered 12 and 18 months after the 3rd dose. While a significant breakthrough, it's important to acknowledge the vaccine only provides partial protection, with research demonstrating it decreases the risk of severe malaria by 30%. Already, the RTSS vaccine has been successfully pilot tested in Ghana, Kenya, and Malawi, with more than 1 million children vaccinated since 2019. Drawing on the pilot, WHO cites a favorable safety profile and no negative impact on net use, other childhood vaccinations, or care-seeking behaviors. Recent clinical trials have also demonstrated the impact of combining RTSS with seasonal malaria chemoprevention, or SMC. A recent trial found that RTSS combined with SMC provided superior protection compared to RTSS or SMC administered alone. Next slide. As you hear from our panelists, please keep the following SBC considerations related to the rollout of RTSS in mind. First, this is the first malaria vaccine. We've waited a long time for this moment, but it's not a silver bullet. Demand is high and introduction will be limited due to supply and cost considerations. The initial focus will be in countries and areas within those countries that have the greatest need, not nationwide. We'll need to be prepared as a global SBC community to manage expectations and anticipate challenges such as myths and rumors. As previously noted, the vaccine requires a 4-dose schedule. This means that follow-up by caregivers to achieve the full schedule. It will require follow-up by caregivers to achieve the full schedule with a 4th dose in the 2nd year of a child's life. The vaccine also only provides partial protection. According to WHO, RTSS prevents 4 out of 10 cases of malaria and 3 out of 10 cases of severe malaria in children who receive all 4 doses. Since the vaccine does not prevent all cases, it is critical that children who receive their vaccine, as well as their family members, continue to use malaria prevention and treatment measures. Finally, there's an opportunity to reinforce messaging around other child health interventions, including immunization services, ITN use, treatment of common childhood illnesses, and more. Next slide. With that, I'm pleased to introduce Elena for her presentation. Drivers of Vaccine Uptake in Eastern and Southern Africa, a literature review to inform RTSS rollout. Remember, as the presentation's ongoing, if you have any questions for our presenters, please feel free to type them into the chat. The floor is yours, Elena.
Thank you very much, Avery. And before I start with my presentation, I want to acknowledge the great presentations and the panelists that appear before me. I think many of the points that I'm going to highlight through this review, literature review, will or are connected with the previous presentations. So just as an intro, I work for UNICEF at the Eastern and Southern Africa Regional Office, and we've been willing to do a literature review to inform the rollout of this very special vaccine in many ways. Next slide, please. I think the context was already presented by Avery, but I want to emphasize the complexity from a social and behavioral change perspective of the introduction and rollout of this vaccine. As we know, the malaria requires different doses that are given in different times apart. Full immunity cannot be guaranteed. And most important, it takes place in a post-pandemic context in which women have been deeply affected by income losses as a secondary consequence of the pandemic. And this is something I think that we should take into account in any interventions that we implement these years and in the coming years, because the recovery to pre-pandemic income generating levels for women, particularly those working in non-traditional economies, is going to take time. So there is a need to understand how people think, how mothers feel, what are the barriers hampering demand and uptake of the vaccine, and what can we do to activate the intentions so that they can not only demand the vaccines, but also uptake them. Next slide, please. The key findings of the literature review, and these we just want to highlight that there is a strong consistency across the domains of the different research. So the one and most important, in my view, is the central role of mothers as a liaison between the experts that are at health facility and families and community members. There is also relevant to highlight the importance of the calculation of opportunity cost and benefit, particularly again in this post-pandemic situation, and the financial and physical accessibility during previous experience. So whether women were able to access health services before taking the children to any vaccination. Next slide, please. Just very briefly, what we do was literature research. We try to find as much articles as possible, not only limited to the malaria vaccine, but also to routine immunization and COVID-19. However, this is a thematic analysis, it's not systematic, so it has some limitations. Mainly that these will help rolling out the malaria, but we cannot ensure that all the fundings are strictly applicable to this vaccine. Next slide, please. So first of all, just to get everybody on the same let's say floor, although I'm sure that most of the people in the call will agree, rolling out and ensuring demand and uptake of any kind of vaccine entails complexity. A previous presenter, and I think it was Dr. Aimable, was saying that we cannot convince people and do just messages. We really need to understand the environment in which caregivers and also health workers act. So for any vaccine, we see all these parameters like knowledge, awareness, supply availability, distance, the need to take a transport to get to the vaccination point, waiting time, service hours, whether they are convenient or not to caregivers, the cost, what is the opportunity cost, and how this is linked to increased poverty levels in our regions. What is the occupation, whether it's seasonal or daily, where this is take place, where outreach is poor, what is the quality of service that is delivered by health workers, and how this is linked to health system strengthening, mistrust either in government or vaccines, whether they need to be mingling with other competing needs and priorities. I'm thinking, for example, of women in Africa with multiple children at different ages. Of course, fear of side effects, rumors that has been mentioned also, gender, culture, social norms, and whether there is social support. So all these parameters needs to be taken into account when we are designing and implementing programs, including the malaria vaccine rollout. Next slide, please. And I just wanted to flag, and this is from the COVID behavior dashboard of Johns Hopkins Centers for Communication Programs. This data is from December, but we can find more updated right now in the web. But when we see, for example, in Kenya and South Africa, what were the reported structural barriers to vaccination of COVID-19, but of course, these are similar to any antigen and also to antenatal care visits, we can see there are no vaccine appointments, or the appointment times did not work, or there was difficulties traveling to site, or leave work or school to get the vaccination, or they couldn't get the type of vaccine they wanted. This is very specific to COVID-19. So I just want to keep in mind this component because I think it's important to realize, acknowledge, and also advocate for the fact that SBC communication alone does not work. We need to work hand in hand with service delivery and within the context of the overall health system strengthening approaches per country if we want to overcome these barriers. Next slide, please. So as per our report, the first point that really stands up in our literature review is the subject of maternal autonomy, because we know that the persons making the decision for giving the children a vaccine varies. It can be the father, it can be the mother. Even in some instances, we've seen mothers-in-law have a role to play. However, as per great literature and field observations in sub-Saharan countries, mothers are normally the ones that are taking the child physically, taking them to the health facility for vaccination and other treatments. Next slide, please. So keeping this in mind and taking the example of Uganda, we see that mothers in Uganda that see their concerns, their need for information and challenges better met by healthcare workers during childhood routine immunization are better able to confidently address their husband's concerns. We know that often we've seen that when the mother comes back with a child to her home and the child has fever, for example, which is something that happens often with vaccines, mild fever, then they see concerns from their husbands who ask for clarifications. The mothers have not received these clarifications from the health worker or the vaccination, therefore they are not able to answer the question. Therefore, the husband will be much more reluctant to support childhood immunization in the next sessions, which is very relevant in malaria, given the fact that there are several doses along the years and that the effectiveness is not 100%. These mothers, they also better perceive the benefits of routine immunization. They understand the importance of honoring the dates and completing the immunization schedule. This is linked to what Avery was presenting. And also they are better able to make cost-benefit analysis. So this is a component that is capital. How do we improve the ability of health workers and vaccinators to actually respond to these queries that come from the mothers, and also to have more empathy and to understand the situation of the moms who are taking the children to vaccination. And when we see in the image on the right, which is quite complex. Again, SBC is not something easy, but I think we can highlight some points that are very relevant, is that maternal autonomy is at the center. If we see the green arrows that go back and forth, the maternal autonomy, as well as the black arrows that comes back and forth from the maternal autonomy point, we see that this is a key parameter that will actually predict whether moms are able and willing to take the child to vaccination. So this is gonna impact the utilization of the health services, which in return will impact the perceived benefit of vaccination, which again will have a direct link to utilization of health services. Next slide, please. So in terms of recommendations, what we would like to promote from UNICEF is to really keep in mind that the promotion of girls' and women's autonomy at all levels throughout the life cycle is essential. It needs to be integrated in any programming, that the improvement of interaction at health facility so that health workers are enabled to answer queries and questions, provide information, particularly on possible side effects, apply opt-out communication techniques. So this is time for vaccination versus do you want to vaccinate your child? And also their ability to develop empathy, I think, is critical. And of course, these require long-term investments, but could come in when we are developing, for example, proposals, and I'm thinking about Gavi. Also the fact that we need to involve fathers so that they get awareness, but also that they fully engage and supportive of their children's health and well-being. Of course, collecting and using social and behavioral data so that we can understand the specific local barriers hampering demand and uptake, and implement multi-pronged interventions, not only focusing on SBC, but going beyond. So how can we liaise with gender colleagues, cash transfer? Can we think about cash transfers to minimize the financial impact, for example, of moms having to take the child to several times to a health facility? Can we adapt the times and location of the vaccination sessions? How can we improve the quality of service? So when we are programming, try to avoid doing SBC in a vertical way, but rather informing other areas of work through the collection and dissemination of SBC data so that all the different components can be adjusted to maximize the impact. Next slide. I'm going to go fast. Sorry, I think it's a little bit long. The other point that we wanted to highlight from the literature review is a calculation of social and opportunity cost. So there is an instinctive calculation of opportunity cost and benefits that influences the parents' decision making in whether they are taking the child to be vaccinated or not. And this is much more impactful than raising awareness. Is really, you can raise awareness, but if the opportunity cost and benefits that is automatically calculated does not fit for the caregiver, then your awareness raising campaign will not be successful. Next slide, please. So there are several parameters when they do this calculation, and there are different parameters that come recurrently in the literature. The rumors, as they were said, but also the perceived benefits of vaccination, the power dynamics within the communities, for example, whether a community has rigid traditional structure and gender roles or not, the trust in people that caregivers discuss with when they are inquiring about vaccines. That can be health workers, family members, traditional religious leaders, also the physical and financial accessibility facility and people's livelihood, as well as service experience. These go hand on hand. And for example, in interview studies across SR, it is common to hear that people walk far to get a vaccine center for the shots, only being told that all the vaccines are finished or that they should come back next week. So, or that the facility is closed. This is something that happens very often. In terms of rumors, for example, we saw in Ghana, just as an example, the lack of WHO approval, loss of fertility, or using Ghanaians as Guinea pigs. This is leading to refusals. This is very much connected, for example, with the rumors that we've been seeing around COVID-19 vaccines. So just like one retrofit others, how can we contain the spread of this kind of information? But I think the most important point is the perceived benefit and the experience of vaccinations. Having experience for themselves, caregivers, the benefits of routine immunization during their own childhood has a positive impact on the decision to have their own child vaccination. So this is all the loops that are created. The more positive experience I have and the more perceived benefits I have and the more convenient vaccination is, then the higher the chances that I will complete the full vaccination for my child. Next slide, please. And I think it's my last one in terms of recommendation. Very important to improve access and convenience by adapted services to people's livelihoods. And for this, human-centered design is excellent. So we have one of the previous presenting mentioning this as a priority for UNICEF SR. We've been rolling out HCD since 2018 and the results are fantastic, although localized. The inclusion of community and religious leaders, they need to be included in all planning and implementation steps, particularly micro-planning, so that we understand what would be more beneficial for them. Publicize the support of trusted influencers so that they feel included, and also that we create a positive local norm around vaccination. Facilitate safe discussion spaces with experts. This is very important in terms of rumor management and misinformation and awareness raising. The way of clarifying doubts, queries, rumors, and misinformation should be interactive and with an expert on the talk to answer these queries. And finally, monitor and counteract the possible spillover from previous experience. For example, having had a poor access to health facility or not having COVID-19 vaccines, that does imply that in this case, this situation will repeat. And I think this is all. I'm just leaving, if you can just move a slide, the different articles that were done for this literature review. Happy to receive more articles if any of the people attending this meeting would like to contribute so that we can expand our findings. And the last slide is just the names of the people that have contributed to putting together this presentation that I hope you have been informative for you all. Thank you very much. Bye.
Thank you so much, Elena, for sharing this comprehensive desk review. As we heard, I think there are many lessons learned that we can use in our malaria SBC work to promote the RTSS vaccine. Importantly, I think the importance of centering maternal autonomy. I think we've seen the important role that mothers play in decision-making reflected within the rollout of other malaria interventions, and seeing that reflected in the literature review, I think really speaks to the importance of ensuring that SBC practitioners address that as we're thinking about the rollout of RTSS. I also really appreciated the emphasis on ensuring we worked hand in hand with service delivery colleagues in influencing the health system to ensure that structural challenges related to vaccine delivery are addressed in order to influence perceptions related to social and opportunity costs. Next slide. Our next speaker is Dr. Rose Hulango, the lead of the Kenya Ministry of Health National Vaccines and Immunization Program. Today, Rose will be speaking about Kenya's experience implementing the RTSS pilot, including many of the SBC aspects. The floor is yours, Rose.
Thank you. A very good morning, good afternoon, everyone. I'm going to take us through Kenya's experience in implementing malaria vaccine with the focus on SBC. I am the team lead for malaria vaccine implementation in Kenya, and I work with the National Vaccines and Immunization Program in the Ministry of Health. Next slide, please. I'll give a little bit of context on where we introduced the malaria vaccine. So you can see the map of Kenya. We did introduce in the western part of the country because that is the area with moderate to high burden of malaria. And within the western part of the country, we selected 8 counties. During the pilot implementation, we did have sub-counties that introduced the malaria vaccine, and those are shaded in purple. Those are the ones who are vaccinating. And then we had the comparator sub-counties, which are shaded in pink. Then we had the sub-counties that were not selected because they did not reach the threshold for the moderate to high burden of malaria. So in those sub-counties that were introducing the malaria vaccine, we did have all the health facilities in those sub-counties administering the malaria vaccine. Next slide, please. We did introduce the malaria vaccine in 13th September 2019, and it was a community launch supported by both national leadership and also the county leadership together with the community. Next slide, please. I'll refer to what my previous speakers have said. So malaria vaccine was not introduced as a standalone. It was integrated into the routine immunization schedule. So it was one of the vaccines that we have in our schedule, but introduced at a sub-national level within the 8 counties. So the schedule that was adopted in Kenya for the 4 doses was the first dose given at 6 months, the second at 7 months, the third at 9 months, and then the 4th dose given at 24 months. Again, the malaria vaccine was integrated with other childhood interventions. So for example, vitamin A administration and also administration of other vaccines, for example, measles, rubella at 9 months, and also deworming. So we tried as much as possible to integrate it with other childhood interventions. Next slide, please. We worked together with the malaria program and introduced the vaccine as a complementary tool and not a replacement to the other interventions that were existing. So for example, mothers who came to be vaccinated, they were still encouraged to sleep under insecticide-treated nets. And then when they have fever, they needed to seek treatment and be treated promptly. So we work together with the malaria program because malaria vaccine is a complementary tool and not a replacement for the other interventions that are already in place within countries. Next slide, please. This is a summary of the uptake of malaria vaccine in Kenya since introduction. So far, we've administered more than 900,000 doses, with the first dose at least 321,000 having received the first dose. But the 4th dose, 64,000 children have received the 4th dose. Next slide. So this is a performance slide for this year between January and June 2022. And in this slide, what we want to compare is the uptake of RTSS vaccine alongside other routine vaccines. So we did compare the RTSS1 vaccine given at 6 months with the pentavalent given at 14 weeks. And the uptake actually quite compared, so they approximated. But as we move further down, so for example, the 3rd dose of RTSS given at 9 months, we approximated to measles rubella 1. What we've learned and noticed is that the RTSS4, which is given in the 2nd year platform of life, the uptake is quite low, and it compares to the measles rubella that we give at 18 months. So this shows it's a challenge not only with the RTSS4, but also the 2nd dose of measles rubella. And this calls for strengthening of the 2nd year platform of life across the board. Next slide. During the implementation of RTSS, overall, we learned some lessons. And one of the key lessons we learned is that it is feasible to introduce the malaria vaccine through the existing EPI structures, because it's the same vaccine that's it's transported like the other vaccines. It's administered by the same healthcare worker, and then it coincides with other childhood interventions. So instead of creating parallel systems, we can strengthen the health system to deliver malaria vaccine within the existing structures. The other lesson we learned is coordination between malaria program and the immunization program, since these interventions are complementary. Community, again, is at the core and at the center of every intervention, because their awareness of the vaccine, their awareness of the disease is crucial in creating demand. And this is one of the aspects that we learned about community acceptance and also community engagement. That goes hand in hand with sustained advocacy and communication before introduction, during introduction, and also to sustain demand across the life course, across the duration of the uptake of the vaccine. Next slide. So in the subsequent slides, I'm going to focus more on the SBC activities that we did during introduction, and also some of the key lessons that we learned alongside during implementation. So before the malaria vaccine was introduced, we had to develop a malaria vaccine communication plan, and we had to align it with the various documents within the Ministry of Health, because the various policies, strategic plans, both supporting malaria and also other childhood developments. So this was done, undertaken by the National Immunization Program and also the Malaria Control Program. Next slide. So as you are aware, we were 3 countries that were piloting the malaria vaccine. So that is Kenya, Ghana, and Malawi. And the first announcement was done in Nairobi. That was on 24th, 2017, of the 3 countries being selected, and also on how they are going to roll out the malaria vaccine during the pilot period. So during this time, there were several media activities. We worked together with the Malaria Control Program to now engage the media and also tell them of the next steps on how we are going to engage in terms of the rollout. So this was a key activity in terms of the rollout during the pilot implementation. Next slide. So again, there are some key activities that we mapped out before introduction. So I'll go through them one by one. So I think I talked about the just putting it together, the communications plan and a risk communication, and also how to engage the media during the pilot implementation. Then we also had a plan on how to engage the media, how to address the media when issues arise, both at the national level, county, and also the community. And alongside that, how to monitor any rumors and how to mitigate those rumors during implementation, because this during anything that any rumor was bound to really affect the uptake during the vaccine implementation. And again, in terms of SBC, there were issues to do with the IEC materials, how to review, adapt into the local context, with a view of engaging the communities, both from the national leadership, the county leadership, and also the community. And also engagement of other stakeholders that I'm going to talk in detail in the subsequent slides. Next slide. So in terms of development of IEC materials, most of the key messages that we developed actually come from, we learn a lot from the CAP assessments that we do in country. And the key messages are actually to strengthen the existing gaps within the existing gaps within the system. So we did receive the generic materials from WHO and worked with in-country partners, that is WHO, PATH, and other immunization partners, to review and adapt in the local context. So from there, we had to pilot test in the community, where we got the community views on how they viewed the IEC materials and also adopted some of the changes. So this was pre-tested in the counties that are implementing the malaria vaccine. And then the final versions were actually translated into the various languages and the dialects within the 8 counties. Next slide. So these are the generic materials that were provided by WHO that we adapted into the local context. Next slide. This slide shows the pre-testing being done at the community level and the national level receiving feedback from the community before final adaptation of the IEC materials. Next slide. And then finally, so this was the output of the reviewed materials and after pre-testing and getting feedback from the community. So this spoke to the community when they were either translated into fact sheets, posters, or even banners. Next slide. Again, for effective communication, we had these IEC materials in different languages: English, Swahili, Luo, Luya, and the various dialects that are within the 8 counties, so that we wanted as the key messages to reach every community member. So we had to translate it into a language they would understand, even if they visited the facility. Next slide, please. Yeah, so that was on the IEC materials. So the other component that we did engage with a lot is the engagement of other professional associations and stakeholders. So for example, we did engage the Pediatric Association. So pediatricians interact with children, both in the public hospitals and the private facilities. So we needed them to, we brought them on board so that they could advocate for malaria vaccine alongside other vaccinations. So the other professionals that we did include are the nurses, the clinical officers, the medical officers, through various platforms, either through their CMEs or their various chapters within the country. The other stakeholders that we also included alongside this are the religious leaders. So mostly the the different religious factions in the country, again, because faith plays a key role, especially in making some of these health choices. So these are important key stakeholders when any new vaccine is being introduced. Next slide. The third stakeholders that we did engage are, of course, the counties. Remember, we were introducing the malaria vaccine in 8 counties out of 47 counties. So we had forums where we talked to the 47 counties on the rationale why we are introducing in only 8 counties. And then within the 8 counties, we also had to interact closely with them to be able to communicate with their communities. Remember, because during the pilot implementation, there were sub-counties that were initially introducing the vaccine, and then there are other sub-counties that were to introduce the vaccine later. So in terms of even communicating, they really had to understand and get key messages right from introduction. So these are the forums where we used to engage the county leadership. So the county leadership are the managers at the county and also at the sub-county level. Next slide. Again, the other key stakeholder is the community, because these are the people who are going to receive the vaccine. And in terms of engagement prior to rolling out the vaccine and also during vaccine rollout, we used different social mobilization methods. So what we used to do are the public address systems, either in the markets where people are crowded, in churches. And this is to give people information about the vaccine and also make a call for the caregivers to come and bring their children to get vaccinated. Then in terms of engagement with the community, we did sensitize the community health volunteers, because these are the people who speak on our behalf when we are not there. So they visit every household telling them about malaria vaccine alongside other interventions. And they also help in defaulter tracking of those children who've not completed all the doses. We also had we used radio again in the 8 counties using the different dialects. so that the messages could reach as many caregivers as much as possible. And then at the maternal child health clinics where we give vaccination, there were health talks. So malaria vaccine health talks were among the topics that were being discussed in the waiting bay. Either it was being shown on TV, even as mothers wait to be vaccinated, at least they were getting information on how to get vaccinated. Next slide. Again, another group of people that we did engage before introduction is the political leadership. And these are the ministers and the governors for health. So governors in every county. So Kenya is a devolved system and every county basically is like its own government, and we work closely with the national level. So I think these are some of the people we had to engage initially for them to understand how the vaccine is rolled out and to get their support in terms of supporting other service delivery elements, for example, transportation, and also calling on caregivers to go get vaccinated. Next slide. We talked about a spokesperson training and risk communication. Again, it was a sub-national introduction, and it was a pilot implementation. So I think we did learn that the media and the healthcare workers interact at one point or the other, and it was very key that the community gets the right message. So we trained the health managers at the national, at the county, and also sub-county on how to respond to media, on how to respond to any crisis that may arise, to prepare them also to engage with media to pass the correct and concise information during these interactions. And again, this was useful in ensuring that all stakeholders are speaking the same language during the vaccine rollout. Next slide. And finally, maybe we are talking about media. I know media can go either way. So media engagement is important during new vaccine introduction, keeping them abreast pre-introduction, during the launches, and even post-introduction, because they are more likely to highlight the benefits of the vaccine and also create demand in the community. And we've seen this a lot with the malaria vaccine. So we've engaged the media before we do any interactions, especially the launches, during World Malaria Day, during World Immunization Day, and they've been very instrumental in advocating for malaria vaccine as a complementary tool. Next slide. So in terms of some of the challenges that we've had, communication challenges, I think is number one, we have a low coverage of the fourth dose given at 24 months. And this is a second year platform gap that we've noticed for any antigen given at the after first year of life. So just creating demand that after first year of life, you still need to come for the vaccine, I think has been quite a challenge for us in the country. Then we had, because it's a 4-dose schedule, initially we had challenges with understanding the eligibility criteria for the healthcare workers. And this is because some of the caregivers would bring their children late. So there was some confusion with the healthcare workers on how to space the malaria vaccine when a caregiver comes late. But this was later sorted out by printing of a one-pager guide that helped the healthcare workers. Instead, children came late for vaccination. So that challenge was actually mitigated. We have the challenge of high dropout rates, of course, between the 3rd dose and the 4th dose. Again, there are different challenges. There are different reasons why mothers don't come for the 4th dose. Either they've forgotten or they got other babies or other competing priorities. So I think this is our next platform on how to strengthen the second-year platform of life for both malaria vaccine and other antigens given beyond 1 year. We have investment immediately to engage the community. So engaging the community means doing training for them, refresher trainings, and also printing materials for them that will guide them when they visit one household to the other. So it's really one of those challenges because it's a high cost driver in terms of investment, but I think it's a worthy investment at the end of the day. Next slide. So what are our next steps for scale up and expansion? So I think what we are doing is to strengthen community engagement. Remember, we had some parts of the country, sub-counties introducing the vaccine, others were not introducing the vaccine. So we'll engage the community so that the comparator areas also create a demand for the vaccine. And then, of course, strengthen demand and social mobilization activities to improve uptake and also to create appetite within the community. We are still going to engage all the leaders that we did engage, the local opinion leaders, administration, religious leaders, and also the professional associations. And then strengthen communication on the second year platform of life, in demonstrating that they need to get their 4 doses for protection. And then working again with the healthcare workers to understanding the eligibility criteria, especially for those areas that are going to introduce later. Next slide. So thank you for your attention, and I want to acknowledge Pat. They assisted in putting the slides together, and over to you.
Thank you so much, Rose, and thank you both for your insightful presentations. Please go ahead and continue to type any questions you might have for our presenters into the chat as we begin our Q&A session with our panelists. So looking at the questions, I think maybe the first question we will begin with for our question and answer session is from Adriana. And I open this question up to both presenters. The question is, the vaccine availability is expected to be quite limited for several years, meaning that introductions will very likely need to be partial or subnational based on the areas of the greatest need. I'm interested to understand from SBC experts how ministries of health can manage communication around introducing a vaccine that has high demand only in specific areas. Rose, Elena, I'm not sure if either of you would like to take a first stab at answering that question.
Excuse me, do you mind reframing it? It cut, I couldn't hear it adequately. Thank you, Avery.
Sure. So I think the question is really about, given the limited demand, how we manage expectations in communication about sort of high demand, but rollout in only specific areas. And so recognizing there's going to be a tension there between the demand and the supply available. Are there sort of recommendations on how that's communicated out to the community broadly?
Rose, would you like to go first, sharing the Kenya point of view?
Yeah. So that's okay. Thanks for the question. And I think maybe I can speak from the lessons we learned in the country. So number one, we are training the healthcare workers, and we have a decision-making mechanism within the country that we only introduce vaccines based on evidence. And we introduce vaccines and take them to the areas where there is the greatest need. And malaria vaccine was not our first vaccine to be introduced at a subnational level. We've introduced yellow fever in 4 counties out of 47 because they were the highest at high risk for yellow fever. And also malaria vaccine, we've introduced in 8 counties because they have the highest burden of malaria disease. So in terms of communication, in terms of what we did for communication, engaging all those stakeholders to help them understand that this is the reason why we are introducing this vaccine in this particular area will go a long way in ensuring that they do understand and support your cause. So investing in the community, in the different professional associations, the media will actually help in passing that message, and even the county itself, the national programs, engaging everyone in making that decision will eventually have all the stakeholders support the decisions that are made by the country. Over.
Thank you, and appreciate that response. I do want to acknowledge we have a limited time for questions, and there's a lot of great questions coming in. So we'll ask a few now, but also welcome presenters to go ahead and answer questions in the chat. And we'll also be keeping these questions in mind as we create sort of our global guidance document through the RBM SBC workstream. Elena, maybe sort of the next question, if I could direct it to you. It's about rumors and misinformation. So rumors and misinformation became a major issue during the COVID-19 vaccine rollout. Are there lessons learned that we might be able to apply to get ahead of the misinformation curve and build global confidence in RTSS vaccine ahead of the rollout? Do you have any thoughts on that?
Yes, of course. Thank you. Thank you very much for the question. This is a recurring question that comes. And the first thing I would say is that we've been tracking rumors on vaccines, including malaria. There is a dashboard that is available, updated every week for the region. So I will put it online in case you want to have a look. We produce reports. IDA from WHO also does it. So lesson number one, you need to track, and you need to do online and triangulate it with offline. So not only what is going on in the media, but also what is being said in communities, and therefore is very important to be, as Rose was saying, engaging with community leaders, with religious leaders, with traditional leaders, women association, and so on, so that you can create these recurring like feedback from communities to be aware of what the discussions are. The second point from our experience these past 2 years tracking rumors in different antigens, HPV, COVID-19, malaria, is that rumors are often not associated with a distrust in the vaccine itself, but rather with a distrust in the system and in political systems and health systems, particularly when political and health systems are weak or do not respond to the needs of the population. So counteracting rumors one by one is normally not effective. What works is providing safe discussion spaces with specialists that people trust. This is very important. So it can be through community dialogues. It can be through radio interactive programs. It can be through ministerial meetings with health professionals that have doubts and queries. Often we need to dislocate the political leaders from specialists. So announcing the rollout of a malaria vaccine will have less rumors if this is done by a health specialist that is not connected politically with governments, rather by a governmental representative. So just to say that when we are managing, responding, understanding what is being said, keep track of what is being discussed, think about being proactive rather than reactive. So providing safe discussion spaces with trusted specialists. And when you need to react, it's better that the reaction is done by a health specialist that is not connected to political figures, so that the information come in a more objective way. Thank you.
Thank you so much, Rose. Elena, sorry, apologies. The next question is for Rose. So this is a question for Rose from Andy. It's about sort of understanding recommendations for working with immunization teams. So Rose, what recommendations do you have for encouraging malaria and immunization teams to work together and to leverage their respective expertise in SBC?
Thanks, Andy, for that question. And what I can say is that I think malaria program and immunization program in terms of malaria vaccine scale up, they actually joint at the hip. And this is the reason. For the immunization program, we do need to be told through evidence generated which areas in a country have a high burden of malaria, and that can only come from the malaria program. So you actually have to work together. They provide the data, we provide the vaccines. Apart from that, we jointly have, we meet in technical working groups where we jointly discuss malaria vaccine, as a complementary tool, in addition to the other interventions that they do give, and the opportunities to leverage. So for example, when a child goes for malaria vaccine at the mother and child care clinic, we have one healthcare worker who is going to communicate to the mother. So both the malaria program and the immunization program are going to work together, generate key messages to give this caregiver, this healthcare worker, who will in turn tell the caregiver that as much as you're getting this malaria vaccine, which you need to get 4 doses, we also have these other interventions. You have to sleep under treated mosquito net. If your child gets fever, they need to be treated promptly. So there are opportunities to work together, especially at the service delivery point, in terms of communication, making guidelines, in terms of training the healthcare workers. So there are many opportunities for the malaria program and the immunization program to work together, both from national up to the service delivery points. So they cannot be disjointed, because remember, this is an additional tool in addition to what they currently provide.
Thank you so much, Rose. Unfortunately, I think that's all the time. I know there's a lot of good questions, but all the time we have for questions now. But we did certainly note that there was a lot of discussion and question in the chat, and we will be sure, sort of as that work stream advance, to keep those questions in mind to help inform the global SBC guidance around RTSS. Thank you again to our presenters for their excellent presentations. I'll now pass the floor to Gabrielle to introduce our next topic. Next slide, please.
Thanks for those wonderful presentations, and thanks, Avery, for your moderating. So we are moving on to the next portion of our agenda for today. This will be our 5-minute lightning talks. Just like yesterday, we have many presentations, so these lightning talks are divided into 3 rooms by topic, and you're free to choose the room that you are most interested in attending. Next slide. So those of you who are interested in presentations on the topic of working with community and faith leaders will remain in this room in the plenary. All you have to do is wait for the presentations to be loaded, and you do not need to select anything. There will be live English, French, and Portuguese interpretation offered for these presentations. On this slide, you can see the titles of the presentations in the Working with Community and Faith Leaders room. Next slide. Our second thematic room is focused on mass media for malaria SBC. And you can see the presentations that will be covered in that room on this slide. This room, due to the limitations of Zoom, will be in English. Next slide. Our third thematic room is focused on provider behavior change and service communication. And again, you can see listed here the 3 presentations that we will have in these lightning talks. And again, due to the technical limitations of Zoom, the presentations in this room will be in English. After the lightning talks are finished, we will all return back to the plenary room for a final session on the future of our SBC working group. Next slide. Welcome back, everyone. I think slowly everybody is coming in from the 2 breakout rooms. Thank you to all of our lightning talk presenters and our moderators, and thank you to all of the attendees for your questions. Those were some really interesting presentations. So we'll now move into our next session. And let's see if we can get the slides up. While we're getting the slides up, those of you who have rejoined the plenary room, remember to select your language using the interpretation button. And we will now begin our final session of our virtual forum, where we'll discuss the next steps for our working group over the coming year. So let's move to the next slide, please. First, let's celebrate some of our successes. I'll go through this quickly because really the numbers you will see on the following slides speak for themselves. So during the last 12 months, the SBC Working Group community has joined our meetings from over 60 countries. And our membership includes a diverse group of SBC experts from national malaria control programs, implementing partners, community-based organizations, and donor organizations. Next slide. We have many successes to celebrate from the last year. A few months ago, we held a webinar on guidance for implementing malaria SBC with Zero Malaria Starts With Me, and we shared some important aspects of SBC programs that should be kept in mind for robust implementation. We also continued the other work streams that you see listed here, and we launched our newest work stream, creating a global SBC guidance for RTSS vaccine rollout. And that's not all. Next slide. The SBC Working Group attended all 4 CRSPC in-person meetings, where we shared our latest resources in malaria SBC to inform Global Fund requests and with the SBC consultant roster of RBM. Our linguistic ambassadors held Lusophone and Francophone networking sessions. We had 19 Lusophones and 61 Francophones attending these sessions. Ambassadors, please take a moment to turn on your video now and wave so that we can all see you and appreciate you. Hi, Susie, waving. And I see Jean coming on as well. So please, any other ambassadors who are on today, we'd love to see your faces and your wave. Thank you. Thanks so much to you for your work over the last few years. Without a doubt, our ambassadors have grown and diversified our membership in a very meaningful way. We also grew our Springboard community by increasing our page views up 40% from 2021. And we've increased the participation on our quarterly general calls over the last 3 years, as you can see on the table in this slide, with over 100 participants on all of our calls in 2022. And this is a really big accomplishment. Next slide. In 2022, we welcomed expert presenters for technical presentations on our general calls. And in the future, if any of you have an idea for a technical presentation for the next year, please contact our secretariat. Next slide. Now it's time to look ahead to the next year. So we would like to hear from you to help guide the steering committee. We have a few brief poll questions for you. Please answer the poll in the Zoom pop-up that should be opening on your screen now. Next slide. I'll just run through the questions briefly. What future resource could the working group develop that would be most helpful in your work? Next slide. The next question is, how can we work more closely with other RBM working groups? Next slide. How can we build stronger connections between SBC and M&E at the country level? For this one, please select the one option that is most important to you. Next slide. And the fourth and last question, What do you see as the biggest SBC capacity gaps in your country? And please select the option that is most important to you. So the poll will remain open for a few more minutes so that you can think of your responses and share with us your thoughts. And we will leave it open as Ashley shares a few closing remarks. So I'll just pass the floor over to her, who will close us out. Go ahead, Ashley.
Thank you, Gabrielle. To our presenters, thank you so much for sharing your knowledge and insight with your colleagues over the last 2 days. And to our participants, thank you for engaging with these presentations with your great questions and comments. We had some really wonderful question and answer sessions over the last few days. The SBC Working Group has a very exciting year ahead. As shared yesterday, the nomination period for 4 steering committee positions and 2 co-chair seats is now open. If you are interested in running for a position and would like to nominate a colleague, please complete the nomination form, which is located in the chat, by October 14th. The Secretariat will share an official meeting report in the coming weeks. The report will share key takeaways, recordings, and presentation slides. Also, please complete a brief survey to share feedback on the virtual forum with the steering committee. The link is available on the slide and in the chat. Please also continue the conversation on Springboard by sharing your key takeaways for yesterday and today's presentations. You can also share any additional questions you might have for our presenters. Finally, don't forget that we have several amazing resources available on endmalaria.org that you can use in your malaria SBC work. Our resources include our strategic framework for malaria SBCC and our indicator reference guide. We also have many M&E resources. We have a special MIS SBCC module and interpretation guidance. We have case studies that showcase the spirit to fight the COVID-19 pandemic and malaria against all odds. And we have our updated COVID-19 guidance. These are just a few of our many malaria SBC resources. Finally, I'm pleased to share that the SBC Working Group has many exciting events coming up, virtual, hybrid, and in person over the next several months. First, the steering committee and secretariat will host an auxiliary meeting for the 2022 SBCC Summit attendees on December 4th, 2022 in Morocco. Please save the date if you're planning on attending the summit. Please contact the secretariat with any technical presentation topic ideas for our upcoming general calls. We'll share that calendar soon. And finally, I'm very excited to share that we'll be planning an annual meeting that will be in person in 2023. Please stay tuned for details, and we look forward to gathering in person again soon. I'm sure everyone will be very excited to come back together. And with that, I will close this year's virtual forum. Thank you so much once again for joining us for the 2022 RBM SBC Working Group Virtual Forum, Malaria SBC in Action. We'll see you in Marrakesh and at our 2023 general calls and our annual meeting. Thank you so much, everyone.
Thanks, everybody.